Hello and welcome back. We are continuing our discussion of acid-base disorder. Next case is a patient with pH of 7.51. If no other relevant clinical information is provided and you would like to know what's the next step in the workup of his alkalemia, what's the next step? Following our basic algorithm, we'll look at bicarb and PaCO2. If bicarb is elevated together with PaCO2, it is metabolic alkalosis. The opposite indicates respiratory alkalosis. We also evaluate the indices that support possibility of mixed acid-base disorder in parallel to clinical evaluation for underlying etiology. Now, if this patient's bicarbonate is 30, what's the next step? Bicarbonate higher than 28 indicates metabolic alkalosis in a patient with alkalemia. The next step is to figure out if patient has normal kidney function or if the patient has got any alkaline substance. Based on that, what are the two conditions to first rule out in any patient with metabolic alkalosis? Before further workup of metabolic alkalosis itself, we need to rule out milk alkali and bicarbonate infusion and renal function. Why renal function assessment is important? Because both alkali administration and milk alkali syndrome are more likely to cause metabolic alkalosis in patients with impaired renal function. Now, in our patient, if the possibility of milk alkali or bicarb alkaline infusion is ruled out and the renal function is normal, what are the next steps in the workup of metabolic alkalosis? We need to evaluate patient's blood pressure. Now, be careful here. Some guidelines mention we need to pay attention to urine chloride, but a better approach is assessment of patient's blood pressure. Why is it so? Because assessment of urine chloride in the cases of metabolic alkalosis only helps if we are dealing with hypotensive patients. What's the whole purpose of checking urine chloride is to see if patient condition and clinical picture is saline responsive or not saline responsive. And that is an assessment that is relevant in patient with low blood pressure. We don't even consider giving saline to patient with hypertension. Second reason is patients with hypertension and metabolic alkalosis always have high urine chloride. So there is no point in measuring urine chloride in patients with hypertension and metabolic alkalosis. Continuing our case, you notice that the patient with metabolic alkalosis has hypertension. What is the next step in the assessment of this patient? Two possible differential diagnoses exist. One is hyperaldosteronism, either primary or secondary, and the other possibility is same syndrome of apparent mineralocorticoid excess. And to differentiate them, we need to analyze PAC to PRA. That's plasma aldosterone concentration to plasma renin activity. What are the three possible scenarios when we evaluate PAC and PRA? We could have high renin and high aldosterone. We could have low renin and low aldosterone. And we could have high aldosterone and low renin. We never have a condition in which we have high renin but low aldosterone. So let's review some cases. Our patient is reported to have high aldosterone and low renin. What is the diagnosis? That's primary hyperaldosteronism. That is suppressed plasma renin activity through feedback mechanism. Can you give examples of hyporeninemic hyperaldosteronism? Adrenal adenoma or bilateral adrenal hyperplasia. Adrenal adenoma is the one referred to as what? Conn's syndrome. Next, based on the differential diagnosis we mentioned, what's the next step in the workup if a patient's plasma aldosterone concentration to plasma renin activity is greater than 15? Remember, PAC to PRA ratio greater than 15 is another way to say we have hyporeninemic or primary type hyperaldosteronism. The next step in the workup is adrenal CT or MRI for the conditions I mentioned, adenoma, bilateral hyperplasia, or rarely carcinoma. Next case, if the results of adrenal CT and MRI are equivocal in the previous case with metabolic alkalosis and increased PAC to PRA ratio, what's the next step? In the equivocal imaging, the next step is adrenal venous sampling to rule out primary aldosteronism. Next scenario is a patient with metabolic alkalosis and hypertension. You perform PAC to PRA assessment and you figure out the ratio is less than 10. What is the diagnosis? The diagnosis is secondary hyperaldosteronism, which is referred to as also what? As hyperreninemic hyperaldosteronism, in which increased levels of renin is out of proportion to increased levels of aldosterone. And as a result, the fraction is less than 10, as opposed to the primary type in which the value of the total fraction was more than 15. What are the differential diagnoses in this condition? Now, the differential is renovascular hypertension, including malignant type hypertension due to renin-producing tumor, renal artery stenosis, or coarctation of the aorta. Next case, a patient with metabolic alkalosis and hypertension with aldosterone to renin ratio of less than 10, has history of headache and nosebleed. What's the first and best tests to perform? Well, this patient seemed to have all the findings compatible with coarctation of the aorta. First test could be chest x-ray showing rib notching, but the best test is echo with color Doppler to confirm the diagnosis. On the other side, if the same patient with metabolic alkalosis and aldosterone to renin ratio less than 10 is a 30-year-old woman with new onset hypertension that was initially treated with ACE inhibitors but recently has shown increased levels of creatinine more than 30% of baseline. What's the diagnosis? That is renal artery stenosis, but because it has happened in a young woman, its underlying etiology is fibromuscular dysplasia. Always remember the hallmark of renal artery stenosis, the so-called renovascular hypertension, especially if some degree of bilateral involvement is present, is increased creatinine more than 30% from the baseline after administration of ACE inhibitors or ARBs. What is the diagnostic confirmatory test in this lady? MRA or CTA. Okay, we discussed two of the three possible scenarios of aldosterone to renin levels. Third scenario is if both plasma aldosterone concentration and plasma renin activity are reduced. What is the diagnosis in this condition? This is same. Syndrome of apparent mineralocorticoid excess. Now, different resources have different categories under this name, but the idea is you have a substance in the body that functions as aldosterone. It could be exogenous mineralocorticoid, it could be a glucocorticoid with mineralocorticoid function, and so forth, so on. So we have a couple important differential diagnoses here. The easiest one is exogenous mineralocorticoid. It suppresses renin and also therefore suppresses aldosterone, while the patient has all the functions of aldosterone. Now, next question is why Cushing syndrome can manifest as a disorder with mineralocorticoid excess. That's because cortisol has mineralocorticoid function. Next question, what is Liddle syndrome? The typical or prototypical example of same syndrome of apparent mineralocorticoid excess is a condition with autosomal dominant gain of function mutation in epithelial sodium channel. Do you remember the function of epithelial sodium channel? It's a sodium channel that is incorporated in the luminal side of the distal nephrons principal cells under the influence of aldosterone, and as its name indicates, its function is to reabsorb sodium from the lumen down its electrochemical gradient. Also remember the role of aldosterone interaction with this channel is the stabilization of this channel. Now, if we have a gain of function mutation in this channel, the channel will be permanently stabilized independent of aldosterone. So sodium will keep being reabsorbed, blood pressure keeps going up, that would suppress the renin-angiotensin-aldosterone system, but all the manifestation and lab findings will be similar to hyperaldosteronism. The only difference is when you check the patient's aldosterone and renin, both of them are suppressed. Next question, you are asked what is the level of potassium in a patient with Liddle syndrome. Similar to hyperaldosteronism of any type, same patients, that is apparent mineralocorticoid excess syndrome patients, will also have hypokalemia. why the patient has hypokalemia even though aldosterone level itself is low and only we have an impaired function in the level of the channel. Remember, the main force for potassium excretion in distal nephron is electrochemical gradient. If a lot of sodium is absorbed from the lumen, the lumen negative potential will go up, and it means increased electrical gradient for excretion of potassium. Likewise, you may wonder why in the absence of aldosterone and only an impaired function of a channel, the patient has metabolic alkalosis in the case of Liddle syndrome. The answer is that lumen negative potential is not only a force for excretion of potassium, but it also provides a means to facilitate HATPase function even in the absence of aldosterone. In other words, the HATPase of distal nephron has two stimulus. One is aldosterone and the other is lumen negative potential. Now that lumen negative potential is increased because of excessive absorption of sodium, HATPase would increase functionality and loss of H+ increases. The second reason is because we have hypokalemia. Always remember that potassium and hydrogen compete with one another across the cell membrane. If there is a lot of potassium going into the cell, it pushes hydrogen out of the cell. But now that there isn't much potassium going into the cell, the hydrogen ions remain in the intracellular compartment, reducing the proton concentration and causing alkalosis. Okay, we discussed Cushing and exogenous mineralocorticoid and Liddle, but a very important category of same syndrome of apparent mineralocorticoid excess is some types of congenital adrenal hyperplasia. You should be able to answer this question. What types of CAH are associated with apparent mineralocorticoid function? Those are the types of CAH that result in buildup of a substance that has mineralocorticoid function. One of these substances are cortisol itself. Now, do you know of any CAH that's associated with cortisol buildup? Well, remember, cortisol, after being synthesized, is metabolized by the enzyme 11-beta-HSD to cortisone. Cortisone does not have mineralocorticoid function. Now, licorice-containing products such as certain candies or flavored tobacco would inhibit this enzyme, resulting in buildup of cortisol, and cortisol will exert its excess mineralocorticoid function. The other example of congenital adrenal hyperplasia are, of course, the enzyme deficiencies in which zone shifting is not moving forward. That is the 17-alpha hydroxylase deficiency. The substances remain in the zona glomerulosa and zona fasciculata. We will have buildup of mineralocorticoids, and that is why this type of CAH causes hypertension and metabolic alkalosis. Another very important example is deficiency of 11-beta-hydroxylase. Please don't confuse it with the deficiency or dysfunction of 11-beta-hydroxysteroid dehydrogenase that is inhibited by licorice and converts cortisol to cortisone. 11-beta-hydroxylase is the one that works on the 11 deoxy compounds and converts them to corticosterone or cortisol. If this enzyme is deficient, the 11 deoxy compounds such as 11-deoxycorticosterone and 11-deoxycortisol build up, and those substances are also mineralocorticoids. You may remember, as a rule, the deficiencies of steroidogenic pathway associated with enzymes that have the 1 in the left side digit, such as 11 and 17, are associated with hypertension. Now, why is it important to know different subtypes of syndrome of apparent mineralocorticoid excess? Because the management of different subtypes differ. For example, if Cushing is the etiology, surgical resection could be the treatment. But what is the treatment for congenital adrenal hyperplasia causing the symptoms of SAME? As usual, we treat congenital adrenal hyperplasia with cortisol. Why is it so? The buildup of substrates that are responsible for the symptoms is because there is no negative feedback on ACTH. So if we provide exogenous cortisol, it will inhibit ACTH and it will reduce the buildup of the substances in the steroidogenetic pathway. True or false? Treatment of Liddle syndrome is aldosterone antagonist. That's false. Why? Because the pathophysiology of Liddle syndrome is distal to the point where aldosterone receptor is located. And also, we already have low levels of aldosterone. So what is the treatment for Liddle? We need to address the epithelial sodium channel that is hyperactive by blocking it directly. What drugs do this? Amiloride or triantarin. We have 3 potassium-sparing diuretics or more, but 2 of them, at least these 2, directly target the epithelial sodium channel, while the other ones are aldosterone blockers such as aldactone or eplerenone. For the other causes of same, address the underlying etiology. For example, ask the patient to stop chewing the licorice-containing tobacco or candy. Sorry, I cannot move to the next subject if I don't ask this question. You have a case of hypertension and metabolic alkalosis, and you are just told that plasma aldosterone concentration is more than the normal range. And you are asked what electrolyte abnormality you can see in this patient. You have been provided values for sodium, potassium, chloride, and bicarbonate. Well, you already know that the patient has metabolic alkalosis, therefore the bicarbonate level should be more than 28. You also know that increased levels of plasma aldosterone concentration in this situation means primary aldosteronism, which also means hypokalemia. But the most challenging part is how to analyze the sodium level. Remember the concept of aldosterone escape? Please always remember there are 2 ways to differentiate primary or hyporeninemic versus secondary or hyperreninemic hyperaldosteronism based on the lab data. One is the levels of renin and aldosterone, or the ratio as we discussed, and the other is the sodium level. In primary aldosteronism, we have increased fluid in the intravascular compartment, including cardiac atrial chambers, that results in secretion of atrial natriuretic peptide, and together with increased renal blood flow, that results in increased filtered load of sodium, we have normalized levels of sodium in primary aldosteronism. This is referred to as what? This is referred to as aldosterone escape. On the other side, in secondary aldosteronism, as in renal artery stenosis, we are dealing with reduced renal blood flow and possibility of edema, either pulmonary edema or other forms of third spacing out of the intravascular compartment. So even though angiotensin may result in increased blood pressure, this is not necessarily accompanied by stretching of the cardiac atrial chambers and release of ANP. Therefore, we do not have normalization of sodium, but instead we have edema. Put it simple, in hyperreninemic hyperaldosteronism, we have possibility of edema and hypernatremia, while in primary hyperaldosteronism, because of the aldosterone escape, we usually have no edema and normal levels of sodium are maintained. Now that said, if a patient with metabolic alkalosis has edema, what is the diuretic of choice? Remember, the only diuretic in the patients with alkalosis that does not worsen the alkalosis is acetazolamide. Remember, all other diuretics are associated with alkalosis as a side effect, while acetazolamide is a cause of renal tubular acidosis type 2, which could be beneficial for patients with alkalosis. Next is a patient with metabolic alkalosis. We rule out alkaline substance intake and we evaluate the blood pressure. He is not hypertensive. Pay attention to the fact that I didn't say he is hypotensive or normotensive. I just said he is not hypertensive. What's the next step in the assessment of a patient with metabolic alkalosis who is not hypertensive? We need to see if the patient is saline-responsive or not. And what do we do for that? We check urine chloride, because urine chloride functions as a surrogate to body's saline status, especially in non-hypertensive patients. What are the differential diagnoses of metabolic alkalosis in a patient with urine chloride less than 20 or less than 25, based on some resources? Simply less than the normal range. Low spot urine chloride indicates GI losses of chloride or laxative abuse or status post-hypercapnia. These are also referred to as saline-responsive metabolic alkalosis. Can you give an example of these GI causes of saline-responsive metabolic alkalosis? Think of upper GI fluid loss, including vomiting, NG tube suction, cystic fibrosis, and villus adenoma. Now, what psych disorders could be associated with saline-responsive metabolic alkalosis? Patients with bulimia or any patient who abuses laxatives. What other compound could be abused by patients suffering from eating disorders? Not only laxatives, but also diuretics. Now, in this specific case, we are dealing with long-term use of diuretics, in which total body's chloride resources are depleted and therefore urine chloride level is low. In recent diuretic use, we will have high urine chloride. We just review this in a minute. What is the management recommendation for saline-responsive metabolic alkalosis? Normal saline. Surprise, surprise. Now, if a patient without hypertension has metabolic alkalosis, and therefore you check the urine chloride and figure out that urine chloride is increased or more than 20, what are the differential diagnoses? This is a very straightforward group of differential diagnosis, and that is either recent use of diuretics or two equivalent syndromes. That's Barter, which is equivalent of loop diuretic use, and Gitelman, which is the equivalent of thiazide diuretic use. How you would diagnose Barter and Gitelman, it's based on the formula of non-hypertensive metabolic alkalosis that has high spot urine chloride or is considered saline resistant, or based on the electrolyte formula you are provided. So what is the electrolyte formula you expect to see in Barter syndrome? We said it is equivalent of loop diuretic, so its pathophysiology is reabsorptive defect of sodium-potassium bichloride co-transporter of thick ascending limb of the Henle. So these substances will be lost into the urine, so we will have possibility of hyponatremia, hypokalemia, and increased urine chloride. Both hypokalemia and loss of sodium chloride, which is accompanied by loss of water, would increase the activity of renin-angiotensin-aldosterone system and result in contraction alkalosis. However, we may not be provided with any of these straightforward electrolyte findings, but urine calcium. Remember, the imbalance of urinary calcium is sometimes our only clue to the saline non-responsive type or Barter-Gitelman subtypes of metabolic alkalosis. What you expect to see as the level of urine calcium in Barter versus Gitelman. If you remember from pharmacology of loop diuretics, reabsorption of sodium, potassium, and chloride in thick ascending limb of the Henle is specifically related to the process of increased intracellular concentration of potassium that would result in a potassium back leak down back to the lumen from potassium channel, again down its electrochemical gradient. This potassium back leak will produce a lumen positive potential that will push the divalent cations, including calcium and magnesium, through the paracellular route and reabsorb them. If the thick ascending limb co-transporter is inhibited by loop diuretics or has dysfunction as seen in Barter syndrome, this entire process will be impaired. There will be no back leak of potassium, there will be no lumen positive potential, and therefore there will be no reabsorption of divalent cations, and therefore there will be hypercalciuria as well as hypocalcemia in patients taking loop diuretics or have Barter syndrome. This is why loop diuretics could be used in the hypercalcemic conditions but has risk of renal stone. Now, how about Gitelman or Gitelman? Well, it's equivalent of taking thiazide that inhibits the early distal tubules sodium chloride co-transporter and loss of these two substances in the urine. Now, if you remember, on the same distal tubule cells, we have a sodium-calcium antiporter that functions depending on the electrochemical gradient of sodium. Now, if sodium level inside the cell of distal tubule is decreased because of the impaired reabsorptive process by thiazides or Gitelman, the electrochemical gradient for sodium to move into the cell and push calcium out of the cell in the basolateral membrane, that is reabsorption of calcium, would be increased. Put it simple, impaired reabsorption of sodium by thiazides, or as seen in Gitelman, would result in enhanced reabsorption of calcium. And that's why we say thiazide diuretics or patients with Gitelman have hypocalciuria but hypercalcemia. This makes thiazides ideal diuretic for patients who have risk of kidney stone or patients with osteoporosis who need diuretic. An off-topic question, but worth reviewing it here. Do you remember one other specific use for thiazide diuretics outside of hypertension or osteoporosis? It's used for nephrogenic diabetes insipidus. Now, do you remember how we compare the effect of loop versus thiazide diuretics in terms of NSAID interaction? Thiazides inhibit prostaglandin synthesis. They are not necessarily considered much of interaction with NSAIDs, but loop diuretics stimulate prostaglandin synthesis, and therefore their vasodilatory effect on afferent arteriole could be blocked by parallel use of NSAIDs. What's the management of saline non-responsive metabolic alkalosis? We need to treat the underlying etiology. I would like to finish this episode with a case of a patient who has history of rheumatoid arthritis with a recent flare, who took some of his maintenance treatment more than the recommended dose and now has come to ER with fever and complaining of new onset ringing noise in the ears. ABG shows normal pH. However, you remember in a lecture you once heard that you should always calculate an anion gap for any interpretation of ABG, and you figure out that the anion gap is increased. True or false? Given the patient's normal pH, admission and close follow-up is all is needed at this point. That is false. Actually, normalization of pH in a patient with high risk of salicylate poisoning as a rheumatoid arthritis patient with new onset tinnitus, hyperthermia, and increased anion gap highly favors late salicylate poisoning with mixed acid-base disorder, which requires quick intervention. Now, what are the possible components of this patient's mixed acid-base disorder? Remember, the salicylate poisoned patients initially have respiratory alkalosis due to stimulation of medullary center as well as hyperthermia. But when uncoupling of the electron transport chain happens and anaerobic metabolism starts to kick in, we will have lactic acidosis type high anion gap metabolic acidosis. And this combination with their corresponding compensations would result in normalization of pH. This case gives us a good opportunity to briefly review the last part of our acid-base formula, and that is the compensation formulas. Well, for metabolic acidosis, the formula is Winter's formula, that is expected PaCO2 to be 1.5 times bicarbonate plus 8 plus minus 2. That is, if your measured PaCO2 lies within this range, you have good compensation. Otherwise, you have mixed acid-base disorder. How about the compensation in metabolic alkalosis? Well, compensation in metabolic alkalosis means we need to see how much respiratory compensation is happening, and respiratory compensation in metabolic alkalosis is increasing levels of PaCO2. The trick in the compensation questions is we never hear what we need to hear, and that is put the values from the mid-range of your normal PaCO2 and bicarbonate. So what does it exactly mean? And this would simplify this concept forever for you, I hope, if in case there was any issues. In metabolic alkalosis, delta PaCO2, that is increased levels of PaCO2 from 40 millimeter mercury divided by delta bicarbonate, that is changes or increased bicarbonate from 24 is always 7 to 10. What do we mean by that? we mean for every 10 milliequivalent bicarbonate on top of 24, we expect 7 millimeter mercury increased levels of PaCO2 from 40. Okay? And now, how about the compensation in chronic respiratory disorder? The good news is chronic respiratory alkalosis and chronic respiratory acidosis have the same formula, and that is delta bicarbonate, again from 24 on delta PaCO2 follows 4/10, which means what? Which means for every 10 millimeter mercury changes in PaCO2, in the case of respiratory changes, we have to have same direction of change for bicarbonate of 4 milliequivalent. Okay, so that should take care of the compensation for now and forever. Remember, we usually do not evaluate compensation in acute respiratory acidosis or alkalosis because it usually takes a couple days for the metabolic compensation to show up in the cases of respiratory disorders. So we have just these 3 formulas, and that's it. Never forget to evaluate anion gap and compensations in cases of mixed acid-base disorder or any case of acid-base disorder if you are required or if you suspect possibility of mixed disorder. Now, returning back to our case, now we know based on both compensation formulas and assessment of anion gap in the setting of normal pH that some mixed acid-base disorder is going on. We need to figure out what's the recommended management. So, true or false? Forced diuresis is preferred to urine pH change in this patient. That is false. Next, true or false? Given that the patient has a possible alkalemia, we can benefit from a drug like acetazolamide that induces acidosis. Remember, that's false. Even if patients with salicylate poisoning are detected early and that is in their respiratory alkalosis phase, we do not want to induce acidosis in them. Can we use other diuretics? No, because the patient has alkalosis already and other diuretics induce contraction alkalosis. So avoid diuretics. True or false? If a patient with salicylate poisoning has pH greater than 7.45, that is detected in the early respiratory alkalosis phase, we avoid urine alkalinization maneuvers. That is false. Remember, as long as pH in salicylate poisoning is not severely alkalotic, and that is a pH of more than 7.55 for this purpose, we still go ahead and alkalinize the urine with sodium bicarbonate. The only thing is we just need to closely monitor a patient's pH. Why is it so? Because the foundation of treatment is increasing urine elimination of salicylate, given the fact that salicylate is a weak acid. Can you give an example of other conditions associated with buildup of weak acid that can benefit from alkalinization of urine? Conditions with buildup of urate, such as tumor lysis syndrome or rhabdomyolysis. Conditions associated with depositions of stones that favor acidemic urine environment, that is cystine and again urate stone. Also remember sulfa drugs, methotrexate, phenobarbital, and of course salicylate among these weak acids that in the case of poisoning could be managed by urine alkalinization. Now, if you are asked about the solution of choice for these conditions and you happen not to see a bicarb containing solution like sodium bicarbonate, pick a bicarb donor such as citrate-based solutions. Potassium citrate or sodium citrate are examples of these urine alkalinizing agents. And if neither bicarb nor citrates are provided, what else can alkalinize urine? You remember we mentioned acetazolamide causes renal tubular acidosis type 2, which means bicarbonate is left in the urine as the luminal carbonic anhydrase in proximal tubule is inhibited by acetazolamide, right? So that is another example of compounds we can use for urine alkalinization. The very final question of this episode, you have a case of diarrhea and stool screen comes back positive for diphenolic substances. What you expect to see in the ABG of this patient? Well, this question is important because, as you may remember from our discussion of metabolic acidosis, diarrhea is associated with non-anion gap, metabolic acidosis, and negative urinary anion gap or increased urine osmolar gap because of the aldosterone distal tubule axis is working properly. However, in this very specific case, we have diphenolic compounds in the stool. And that means the patient with diarrhea has laxative abuse problem. You can look at a patient who is probably a female healthcare worker with multiple hospitalization, and this could be a clue to a type of eating disorder. Remember, the patients with laxative abuse, as we discussed, have saline-responsive type of metabolic alkalosis. Do you remember what is the colonoscopy of this patient report would say? It will say the colon resembles alligator skin because of dark brown discoloration with patches of lymphoid follicles, the pattern referred to as melanosis coli. This, together with diphenolic substance and clinical picture, are sometimes your only clues to diagnose laxative abuse. So once more, if you have a patient with metabolic alkalosis, first rule out alkali ingestion, then see if the patient has high blood pressure or not. If the patient has high blood pressure, evaluate the plasma aldosterone concentration and plasma renin activity for 3 possible scenarios of primary, secondary hyperaldosteronism versus same syndrome of apparent mineralocorticoid excess. However, if the patient does not have hypertension, check urine chloride to see if the patient is saline responsive with low urine chloride or saline non-responsive with high urine chloride. Remember, differential diagnosis of urine chloride more than 20 or saline unresponsive type is Barter or loop and Gitelman or thiazide, while if the patient has saline responsive type, you are dealing with GI loss or psych disorders or compensation of hypercapnia. We discussed the respiratory acidosis in respiratory failure episode, and we briefly discussed the respiratory alkalosis and its associated conditions with panic disorder. The real challenge in acid-base disorder, however, are the metabolic conditions, and this finishes our discussion of metabolic alkalosis and our discussion of acid-base disorders.